Welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello, Rhonda.
Good laugh to start 2021. Welcome.
Yeah.
Welcome, everyone, to episode 224. And I want to start off by saying a quote from Esther Perel, who is a psychotherapist, and she made this statement: "Life will present you with unexpected opportunities, and you won't always know in advance which are the important moments. Above all, it's the quality of your relationships that will determine the quality of your life." And I'd like to say that when I walked into your intensive in 2013, I had no idea how important that moment would be for me and how it changed my life, both personally and professionally, for the better. And I want to really thank you, David, for the relationship that you have with me and the quality of the relationship that we have and everything that you've given me. And I just want to start off with 2021 and this new year with the podcast saying, I really love you, and I really am so grateful for everything that you've taught me.
Well, thank you, Rhonda. I feel exactly the same way when it comes time for us to do our Tuesday at 1 o'clock recording, or is this one, 3 o'clock? This is our second podcast. It just always brings me a lot of joy, and there's so much love in your voice and so much happiness and peace. And it just so great that we get to hang out. I feel enriched by you, by all of the people in our community, and it's just been fantastic.
Yeah, one of the things that strikes me about people who are attracted to do team therapy is the kindness and compassion that they show towards each other, towards other therapists, towards their patients, and I think that comes from you teaching us about empathy and 5 secrets and making sure we're stroking and disarming and putting other people's, listening and putting other people first before we put ourselves out.
It rubs off a lot. I've learned a lot in that regard from you. I've learned a lot from Jill. I've learned a lot from other people, and we're lucky to have a group that's accepting and positive and reinforcing. It just makes it a lot of fun. I've been in situations, academic, like at Penn, and sometimes I've heard it's that way at Stanford too, where people are just very competitive, and it's not necessarily a real warm, working relationship, and people have the perception that they're in competition with each other, which in some ways in an academic center you are, but it's just so nice to have people. I get so much help from everybody in the group, and it means a lot. Mm-hmm. I think I may have mentioned this on a podcast, but I mentioned it to someone recently. But the group that I mentioned, like how it used to meet in my living room, our Tuesday group.
Yes. Was that when there were like 12 people in it?
Well, 12 or 15 or something in that range. And I told you about that one young woman who would cry at the end of the group.
No.
Because she said it's going to be a whole week before we get to do this again. And she said, I just feel closer to the people in this group than to my family. And she also said that she cried driving over to my house because she saw these pretty houses and they have families and loving couples. And she said, I don't think I'll ever be loved. She was a beautiful young woman, like a model, really. And but now she's happily married and has a child. And
nice.
But it was just so touching to hear what she said. Well, let's dive in here and
Okay,
make some.
Let's start with something kind of interesting and controversial. We did podcast 220 where we interviewed Stephen Hayes, who's the founder of ACT, and you got a lot of emails about that, and we thought we would read about just a few short ones. And we want to also say that you can go to David's podcast page for a lot more comments, including some fairly intense ones, praise and criticism, but none indifferent. So I thought that was interesting.
Absolutely. Yeah, we kind of stirred things up with a controversial podcast, and I was pretty proud of how we did, although I got a couple of real hate emails from it, and I think people don't like to have someone they admire criticized at all. And yet we got a tremendous amount of praise as well. Read a couple of them there.
Yeah, well, Derek wrote, "Hi, David. Thank you for that great podcast with Stephen Hayes, the meeting of minds of two pillars of modern day psychological wisdom." And that was cool. And then Angela wrote, "I think this podcast showed a willingness to listen and even connect with someone with different ideas. And that's living what you preach. We can't learn new things if we think we've got it all figured out." And then someone named Moon Nav wrote, "That was a terrific conversation." And then the last one I'm going to read, somebody sent you this email. "Thank you, David, for speaking up and saying you didn't understand. I also didn't understand." Those are
well. Thanks for all of that feedback, and we really appreciate your interest, your support, your praise, your criticisms. It gives us a chance to learn and grow from all of you, just as we're hoping to bring learning and growth into your lives as well. Mm-hmm. And we've got 7 great questions here, so why don't we dive in?
7? I only have 6.
Well, I sent you one earlier. There's another cool new question, and I'll read it when we get to there. It's the last one because I think you'll enjoy it.
Okay, great.
Especially.
Well, Josh asked you, what are the most effective types of psychotherapy homework assignments? "Hi, David. Thanks for all your work. It's been very helpful. You mentioned that doing homework is essential to recovery from anxiety and depression. Is there any homework you recommend? Anything that would benefit?"
Yeah, well, we can shoot the breeze on this one briefly. It depends on the kind of problem that you're working on. I just made a brief outline here of if you're working on depression, anxiety, or relationship problems. You always want to include bibliotherapy in your homework for your patients. If they're depressed, they can be reading my first book, Feeling Good, or the Feeling Good Handbook, one of those two, or my new one, Feeling Great, and encourage them to do the written exercises in the book while they read. If it's anxiety that the patient is struggling with, they can read my book, When Panic Attacks, that has 40 techniques for overcoming all forms of anxiety. It's not just on when panic attacks, but all 12 of the classic anxiety disorders. Let me just, I got to turn my recorder on. It wasn't on. It says battery low. Yeah, there's a problem on my recorder here. I'm just going to turn it off.
Okay, well, we'll just use the Zoom recording then.
There's some adjustment, but we can record on Zoom. And if it's relationship problems, they can be reading the book Feeling Good Together, which is all about the 5 secrets of effective communication. Another thing is written homework. So if it's depression or anxiety, they can be using the daily mood log and recording negative thoughts, identifying the distortions in them, that type of thing. If it's relationship problems, they can be working with the relationship journal. What did the other person say? What did you say next? Was this good or bad communication? What are the consequences of responding the way you did? And what would be a more effective response using the 5 secrets? Coming back up to depression, other homework besides the daily mood log would be using the pleasure predicting sheet, also maybe testing self-defeating beliefs like, if I'm not loved, I can't be happy, or nothing's worth doing unless I do it perfectly, things of that nature. And if it's anxiety, the patient should be doing exposure techniques, or if they're shy, between sessions, they could be using the survey technique, or flirting training, or rejection practice, or shame attacking exercises. And you can do some of these with the patient as well. And for depression, anxiety, and relationship problems, the patient can be using the assessment instruments, taking them before and after sessions, or as often as they like, to be tracking their moods and tracking their progress. Those are just a few, of the kinds of homework assignments you can use. Can you think of others that are particularly helpful?
Because I only have 1 hour sessions most of the time, wherever I am in the process, in the team structure, I'll have my clients or my patients do homework to continue what we're doing. For example, if I've gone through the daily mood log and we've identified the emotions and the negative thoughts, but we didn't get a chance, and then we started the positive reframe, but we don't have time to finish it, I'll ask them, especially if we started it a little bit together, to do more positive reframing as their homework. And if we've gone through the positive reframing and identified some cognitive distortions, in some of the negative thoughts, especially if we've generated a lot of thoughts, I'll ask them to finish identifying the cognitive distortions in the rest of their negative thoughts, and then go through the new technique that you have, explaining the distortions, and ask them why the distortions are thinking errors and why they're self-defeating. So I just have them continue the process on their own to reinforce it.
I love what you're saying. And then another important one I forgot is I insisted, and to this day insist, that the patients record every session. Mm-hmm. And in this modern era with cell phones, they can just record it on their cell phone. Or if it's a Zoom, you can automatically just click the record button and send them the recording, or have them record. But I made my patients listen to every session, between sessions, to listen to the recording, and they typically said that they got much more out of the recording than the actual session. So that's another really tremendous thing that almost no therapist does. Alex in our group, I think, does that. Do you do that?
I do that, and people find it so motivating.
Yeah,
really helpful.
Okay, let's push on to Hassam.
Okay. Well, Hassam wrote, "How would you treat my severe OCD? Exposure doesn't seem to be working. Hi, David. I love your work on the podcast. I have not yet found a copy of any of your books in Lahore, where I live, but I have grown to understand your philosophy through your podcasts. Episode 162 disturbed me a little. I suffer from severe obsessive-compulsive disorder and its cousin, depression. And the high-speed cure in the title really attracted me. But I had buyer's remorse. Why? Because it doesn't work like that for most people. The guest on your show had a few exposures and bam, she was cured. I've tried exposure many, many times, and it very minimally helped in lowering the threat of my obsessions. I feel that this was a magic pill kind of account, and at the risk of judging a person's pain, I think your guest had a relatively mild, as compared to me, form of OCD. I would really love it if you could talk about pure OCD, the type I have, and how it can be resistant to exposure. The intrusive thoughts, obsessions continue to be extremely, extremely painful. This high-speed cure idea seems dismissive of the seriousness of my condition. Please keep up the great work, and I hope to read your books one day. Thanks, Hassam, a therapist in training."
Great. Well, thank you, Hassam, for your kindness in spite of your annoyance. It's always great when you get feedback from people, and of course, there will be a bell-shaped curve of difficulty with anyone with any disorder. Some people responding relatively faster, and others being more resistant. But one big thing that I would say is that I've always promoted the idea that exposure is not a treatment for OCD or for anything. And I never treat a disorder with a technique. Now, when I'm showing a patient who recovered, I'll often show the technique that worked for that person. But that treatment, including the treatment with Sarah, who recovered so quickly with her OCD, was embedded in the team model of testing, empathy, assessment of resistance, melting away resistance, and then using a wide variety of methods. And if you go to my podcast on the treatment of anxiety, you'll see that I treat every patient with 4 different kinds of methods. The cognitive model, the daily mood log, and writing down the negative thoughts, identifying the distortions, and crushing the distorted thoughts. The motivational model, which is extremely important, and most therapists don't know how to use the motivational model to bring the patient's outcome resistance and process resistance to conscious awareness. And if you don't do that first, you're going to be really up a creek in the treatment of not only OCD, but all anxiety disorders and depression and relationship problems as well, because everyone has mixed feelings about recovery. And part of us wants to get better, but particularly with anxiety, the patient fears, boy, if my obsessions disappeared or if I stopped doing my compulsion, some terrible thing would happen. And so the OCD patient subconsciously, and all anxiety patients subconsciously believe the anxiety is helping and protecting them. And unless you deal with that, it's going to impair or sabotage the treatment. The third model that I use with everyone is the hidden emotion model. And you can read about the hidden emotion model as well as all of these in my book, When Panic Attacks. But there's a great section on the hidden emotion model. We've had a number of podcasts on the hidden emotion model because most OCD patients, I would say 80%, and most anxiety patients as well, have some problem that they're not dealing with. They have negative feelings. They're sweeping under the rug, so to speak. And then those problems come out indirectly in terms of a phobia or generalized anxiety or panic attacks or OCD or any form of anxiety. And bringing those hidden emotions to conscious awareness can be incredibly helpful for people who are otherwise stuck. And you can hear this on the podcast too. The search function on my podcast is temporarily somewhat screwed up, and I'm trying to get it fixed. But ordinarily, you can just type in like OCD in the search function or anxiety or depression in the search function and find a lot of great podcasts. And the fourth model is the behavioral or exposure model, the one that you're referring to. But if a lot of therapists are looking for one formula, like, oh, I'm going to treat everyone with exposure who has anxiety. And I've spent my entire career saying, don't do that. But therapists usually don't listen to me. They do kind of what they want to do, and everyone's looking for a bit of a formula because it seems easy to learn one thing. Most therapists won't do exposure because they're so afraid of it. Others probably overdo it, and I never treat a disorder. I treat a human being using all of these models.
Do you ever use the habit and addiction model with OCD?
I never have, but you could if you could use it with the compulsion, the thoughts. Oh, I've just got to get up and check the stove again because maybe I left the burners on. You've already checked the burners 3 times, but yes, you could do that very, very well. Have you done that?
I have. I thought you taught me that.
I might have. Yeah. Yeah, that's definitely another tool. And I might put a thought in the middle of a recovery circle, and then I would have at least 20 techniques in the recovery circle. So exposure would be one of 20 techniques. But Hassam, you may be hung up due to the hidden emotion model, the motivational model, or the cognitive model that need to be included in the mix if you're really looking to get dramatic results from the majority of your patients. And then another
Then Joe asked you the same thing, a follow-up. Like, would you say the secret to overcoming OCD is willpower?
Yeah, and I would say I've never used willpower as a treatment for OCD, although you have to be willing to do the exposure. But I use these 4 models, and you can read all about them. Pick up my book, When Panic Attacks, and read it, or use the search function on the website, and you can get all of the podcasts on anxiety. There's also a free anxiety class on my website, feelinggood.com. You can take an anxiety test, and you'll get an interpretation back in the email showing exactly how anxious you are. And then there's a class that you can take, getting the podcasts on anxiety, starting with the basic model for treating anxiety, how does team therapy work, and then going into all of these models for the treatment of OCD, phobias, panic attacks, generalized anxiety, or whatever.
Well, I hope this is reassuring to Hassam, because it sounds like he's focused on one technique, exposure, and you're saying that there are lots of different things that he could try.
Yes, and then if he's a therapist in training, he might want to try to learn team through one of the fabulous groups at the Feeling Good Institute, like one of Mike Christensen's introductory training, 12-week training on how to do team. And also the fabulous Rhonda Borofsky has a Wednesday training group.
I was going to say, I think he could email me at Rhonda at feelinggreattherapycenter.com and see about maybe getting on the waiting list for my, the group that I'm doing with Richard Lamb and others.
Yeah, that'd be awesome.
Yeah.
Okay, on to
That's
Ted.
Zooming through these. So Ted asked you, does any psychiatric disorder result from a chemical imbalance in the brain? Hi, Dr. Burns. It says in your book, When Panic Attack, on page 49, in the 3rd paragraph, you wrote that there's
Which sentence in the 3rd paragraph? I feel like you're in court about to be attacked by the prosecuting attorney. Here's what you said during deposition.
I know. That's what I thought. It says in your book, When Panic Attack, that there's not one shred of evidence that there's any chemical imbalance for any psychiatric disorder. Does that include schizophrenia or bipolar or OCD? Haldol works for me for schizoaffective disorder.
Yeah, right. Well, there's 2 different issues going on here. One is the theory of a chemical imbalance in the brain of any value and understanding brain function, and the answer to that is no. That idea has been discarded by neurochemists and neuroscientists for several decades. This imbalance theory goes back to the medieval times when they thought that all of nature could be explained by different imbalances between earth, air, fire, and water. You remember that?
No. That's interesting.
Well, those are the medieval theories. That was physics. Those are the basic things: earth, air, fire, and
they
water.
All are embedded within all of us, and then out of balance.
Yeah, and the balance and imbalance of those explains everything in nature. And then that turned out to be a worthless theory. And then it crept its way into medicine. And then medical disease, they tried to explain it as an imbalance of the 4 humors.
I remember that.
Blood, bile, and 2 other humors, blood, bile. Hippocrates actually, I think, got that one started way back a couple thousand years ago, the father of modern medicine. But when George Washington, for example, had some terrible throat infection, all they could do was work with these 4 humors. So they figured, well, he has a blood imbalance. So they bled him almost to death. And then he did die, thinking that to get this bad blood out of his body, that there was a blood imbalance. But that idea of medicine as being the balance of 4 humors, like say blood, bile,
phlegm?
phlegm, maybe, yeah. Is that when you got like snot in your nose or something? And then also melatonin, the black
bile, yellow bile.
Yeah, whatever. But anyway, that was a worthless theory. And then it got into psychiatry. In the early days, they were looking for theories so they could get grants from the National Institute of Mental Health to study, schizophrenia and so forth. So they had this chemical imbalance, like depression is due to too little serotonin and mania is due to too much serotonin, or psychosis, schizophrenia is due to too much dopamine or some such thing. But these are worthless theories. They're not sophisticated. It's like trying to diagnose an automobile engine by a balance of gas and water and oil. That's not how you fix an automobile engine. And so that's the answer to that. Now, are there biological causes, biological abnormalities in schizophrenia? Yes, absolutely. But it won't be a chemical imbalance, and we don't know what it's going to be, but it'll be some very basic abnormality at the level of brain tissue or enzymes or how neurons connect and don't connect. And in mania too, it will be there's a biological cause. It's just not normal. More of normal behavior. Mania is not just an excess of happiness. It's something bizarre and abnormal and sad. So there are biological disorders. Now, there isn't any evidence yet. We don't. There's probably some genetic contribution to depression and to anxiety. My mom had anxiety. I had anxiety, but we don't know how those genetic influences play out or how they're manifested. What genes are involved? No one's figured any of that out.
Isn't there also a continuum?
Not paid off there. What?
Isn't there also a continuum of how the genetics plays out with our environment and how we're raised? Like, you might have a predisposition to depression or anxiety or schizophrenia, and if you have the optimum, environment when you're raised, maybe those conditions or symptoms won't manifest with you.
Right. And those are all just kind of BS theories that people make up so they can think that they're saying something halfway intelligent. But when we really find out the cause of schizophrenia, we'll look back at all these theories and say, boy, that was a lot of baloney.
Well, it would be really great if there could be a blood test and someone would take a blood test and it would be analyzed, and then they'd say, okay, well, you're missing a percentage, you're missing dopamine, or you're missing this, you're missing that. And then we'll give you this medication and it'll make that up and now you'll be fine. But we don't have that kind of a test.
The hope is that when we find the cause of these things, like when there were theories about the causes of polio throughout history and the causes of epilepsy, and the treatments were bizarre. Mm-hmm. And then once we found that polio resulted from a virus, and then we got a vaccination, and now we're done with it, and all the theories of history are of little interest to anyone anymore. And the same way for epilepsy. In some day it'll be the same for schizophrenia, and hopefully we'll have some treatment. I feel so sad when people have schizophrenia, because it's just a horrible affliction. It's kind of like brain cancer. It's not brain cancer, but it's very, very severe. And I'm sure the result will be biological. But when we have depression and anxiety, we can say there's a huge role there for negative thinking. And when you change the way you think, you can change the way you feel, and often quickly. And that there is good news. So that's my answer to Ted's excellent question.
Okay. So Brian asked you, Dr. Burns, could you do a video on how to use CBT for stress? Thanks.
Yeah, that's a great question. Stress does not exist. It's just a buzzword, and it means whatever you want it to mean. It means somebody's unhappy about something.
Well, how would you say? Well, how would you answer that if somebody said, I have a newborn baby who doesn't sleep and is always crying, and I also have to work. Well,
if you read the first, stop where you are, okay? Mm-hmm. That's the first chapter of Feeling Great, is on a woman who has postpartum depression because she's having trouble connecting with her baby. And then we did a daily mood log, wrote down her negative thoughts. What do they show about you that's positive and awesome?
I'm not talking about depression, though. I'm talking about so many things that are going on in your life that you can't manage it, and you're feeling that you can't, or you're thinking that you can't manage it, and you're feeling stressed out by everything that's going on.
Well, see, I can't help anyone with everything that's going on, and neither can any other human being. In fact, it's meaningless because there's trillions of things going on in the universe at any moment. Exactly. And so it's just a kind of a garbage question. But what I'm driving at is give me one moment that you were feeling stress. Uh-huh. What time of day was it? How were you feeling? And then we can take a look and see what was going on in that person's life. And it might be an individual mood problem. It might be depression. It might be anxiety. It might be a relationship problem. For example, maybe you're having adversarial interactions with your boss, and you may need to learn the 5 secrets of effective communication. But the point that I'm trying to make is people have the erroneous idea that something like stress exists and then a cure for stress exists. So they're looking for these general tonics like meditation or vitamins or aerobic exercise or deep
like
breathing.
An easy answer, yeah.
Or formula kind of thing. And TEAM is not about formulas. It's about individualizing the therapy for everyone. Now, all that being said, when people talk about stress, one of the things that they might most often be referring to is that they've taken on too much.
Uh-huh.
And
yes, I totally agree with you.
Yeah, and that they're overwhelmed by having too much to do. And then you'd have to take a look at it and see why that is. Mm-hmm. And sometimes it turns out that they have trouble saying no or being assertive. And they may have like conflict phobia or excessive niceness, thinking they always have to say yes. They may have one of the self-defeating beliefs called submissiveness or pleasing others. Mm-hmm. Another thing, sometimes people get overcommitted due to fear of missing out on something really cool and something really, really exciting to do. But stress is never caused by what's going on, right, Rhonda?
Yes, exactly.
It's always caused by your thoughts and how you're interacting with other people. And that's good news because that gives us a lot of great tools like the daily mood log and the relationship journal. I might say that when I was in Philadelphia, I was invited to go to New York and be on a TV show about my book, Feeling Good. And that was very exciting to me because it was hard. It's hard even in this era to get publicity, even for my new book. It was very hard for my first book, Feeling Good. And so to be on a New York, a local Manhattan TV show, that was really big time to me. And they even made cartoons of each of my 10 distortions, like all or nothing thinking.
Oh, how fun.
Yeah, so it was really cool. But on the train up to New York, I realized, but they were going to, the name of the show was, how to deal with stress. And I realized on the train that I didn't know what the word stress meant.
Oh, interesting.
Because I'm always working with depression or shame or, the words on the daily mood log. And then I got all stressed out because I didn't know what stress was. But the show went really, really great anyway. But
can I tell you a story about that too?
Yeah.
Now that we're sheltering in place, I'm watching my husband's work habits, and he's a lawyer, and he had this. He had a brief due, and he didn't procrastinate for one moment, and he was never really that stressed out. He just methodically finished his brief. And then when he was finished, he felt happy about it. And I thought, gee, he is not a procrastinator. And I am at times a procrastinator. And I had a report to do myself for a family that I was working with. And I procrastinated for a month. And I was feeling so much anxiety.
Oh, boy,
and then I kept watching Michael. He's so calm. Why is he so calm when he has this big thing due? And why am I so stressed out? And then it dawned on me, because I'm procrastinating. And then as soon as I realized I was procrastinating and that was causing my anxiety, it kind of motivated me to finish. But it was an interesting watching and comparing his lack of procrastination and his commitment to get things finished in an easy, methodical way. He's really calm and not stressed out.
Yeah, that's cool. Now I have a new technique we can practice.
Okay.
It's called and you've got light in your eyes too.
I know, because the sun's right in my eyes. I keep moving around.
It's called no practice.
Okay.
And no practice is the best practice.
Okay.
And the way it goes, a lot of people have trouble saying no.
Okay. So no practice.
Yeah, isn't that cool?
Yeah, I love it.
We could take turns putting pressure on each other, trying to get the other person to do things.
Okay.
And then you have to try to say no, and then the pressurizing person tries to put on maximum pressure.
Okay.
So you want to be the one who's coercing David, or do you want David to coerce you? Do you want to be the one practicing saying no?
No, I want to coerce you.
Okay, great. Cool.
Okay. David, did you see that email I sent you? Can you look at the email and respond to it? And I need you to, can you do that like within the next few minutes?
Oh man, I'd love to do it, but I'm doing a beautiful podcast with Rhonda right now, and I'm tied up with a number of things. But I'll definitely take a look at it in the next day or two.
But I'm trying to get an article accepted into a peer-reviewed journal, and I really need your editing. Is there any way you could take a look at that before tomorrow?
Not really. I'm just blasted up to the top of my head with stuff, but I'm excited for you and proud of you to having something for a peer-reviewed journal, and I'm flattered that you'd ask me, and I wish I did have the time to do some editing for you. How did I do?
That was pretty good, because I didn't feel so bad, because you're so kind and thoughtful, and you're no.
Okay, now let's try a role reversal, okay?
Okay.
Yeah, Rhonda, I've got this. I want to submit these articles about my new book. This website wanted me to write some, articles on the cognitive distortions, and I need the first one by tomorrow. And I know it's late, 10 p.m. and all of that, but I was wondering if I could just send it off to you. It's only about, 6 or 7 pages, and if you could just do some of your wonderful editing for me.
Oh gosh, I love editing for you, and I would love to do that, but gee, at 10 o'clock, I'm pretty tired. I'm kind of surprised I'm even talking to you. And
I understand that very well, but there's a couple things. First, you are such a brilliant editor. Even when you're sleepy, you're better than 99% of the people on the planet Earth. And this is tremendously important. Might generate some referrals, and I can send to your new Feeling Great Treatment Center.
Oh, gee, it's so flattering. I hate to disappoint you, but I'm still going to have to say no, because I'm so much better in the morning, and I really need to give my brain a break. So I'm going to have to say no, but I could do it in in a couple more days.
No, I need it. I got to get it submitted before midnight tonight.
Before midnight tonight?
Yeah, and I really need your help.
Well, okay.
It would mean a lot to me.
You win. I'd say okay.
You're caving. Do a role reversal. Or try it again. See if you can do better.
Okay, David, I really want to get this article into this peer-reviewed journal, and they told me that they weren't going to accept me because my thesis was naive, but if I turned it into them by midnight tonight, they'd accept it. And then more and more people would learn about team, and in a different kind of community. I really need you to take a look at it, because I want to make sure it's accurate. And I know it's 10 o'clock, but this would really benefit you too.
Yeah. I love you to death. I'm so proud of you at, submitting someone to a peer-reviewed journal would be just so awesome. I'd love to be helping you out, but today just isn't going to work for me.
But really, you're not just helping you out, you're helping yourself out.
I know. Anytime I interact with you, it's helping myself out. Because
because I talked about team and David Burns, and I referenced your book. So when my article gets published, if it ever gets published, you would get benefit from it too, because it's, publicity for you.
Yeah.
So it would just really take you a minute, because it's only 6 pages.
Yeah. Well, I'm really flattered to be asked, but it's not a best time for me. I'm actually in an ambulance heading to the hospital at the moment. I was in a car accident. I've been hemorrhaging, so I'm going to have to say goodbye for now, and best of luck on the article. I'm thrilled for you.
That's great. But you have to go to a pretty extreme.
But anyway, those are a few of the ideas, and essentially, the short answer is that I wouldn't deal with the word stress any differently from the way I would deal with anyone who comes to me for help. And just say, when you say you're under stress, you're telling me quite right in your life, and I would empathize and have the person talk about it and provide warmth and support. And then I would say, is there a specific thing that you've been talking about that you'd like some help with? You talked about a problem at home and problem at work and problem with X, Y, and Z. And I work the best by focusing on one thing at a time. And if there's one of those things you'd like some help with, I'd be delighted to work with you if you feel ready to roll up your sleeves and get to work, and then have the person focus on one thing and then conceptualize, is this a relationship problem, a depression problem, an anxiety problem, a habit or addiction problem? And then whatever it is, use the appropriate tools, melt away the patient's resistance, and then use interpersonal technique, like what we just illustrated, or maybe it's talking back to the tempting thoughts to get overcommitted. Oh, I'd be so excited to be on this new committee at Stanford, and it would only take me 6 more hours a week of work and and stuff like that, and sometimes saying no internally. I know when I was in Philadelphia, there's a fellow Steve, I think it was Steve Sayers, was a postdoctoral fellow or a psychology graduate student getting his clinical hours at my clinic. And I was thrilled to work out of good family that I wanted to learn. But when he came, he said, I want you to know that my time is very limited. I'll give you the full time that I'm supposed to spend at the clinic, but I won't be able to spend a lot of extra hours in the evenings because I have other commitments. So he just set that limit right away. And so I said, oh, okay, that's fine. But I really respected him, setting it up like that. And some people go in thinking you've got to, please everyone and say yes to everyone, and then you get kind of overcommitted.
This was really cool.
3 more questions.
But, you're saying too, but specificity is one of the steps in the team model.
Yeah.
And you're asking about getting
crucial.
Really specific.
Yeah, because, you could be stressed out by an infinite number of things. And they might all require an individual solution, not some, oh, you're stressed, do meditation, close your eyes and say, Om, or whatever it is, or exercise, or, breathe deeply.
Hyperventilate. All right, here's Clarity's question. She asked you, is it too late to be a beta tester for your app?
Quick answer. No, you just go to feelinggood.com/app, and you can sign up there to be a beta tester. We're starting to do a lot of beta tests, and we're getting some very promising and exciting data. We're analyzing data for the first time with the beta testers and seeing how much improvement in mood they're getting, and after how many minutes with the app. And the data looks pretty fantastic. I'm going to present some of it at the first team meeting for 2021 on a Tuesday evening.
Oh, sweet.
And just show a little bit and maybe present the award also for our contest at that time. But that's all you have to do, and we appreciate any of you who want to beta test the app. Our goal with the app is to create an app, the first app that will be shown to be more effective than a human therapist.
Oh, no, don't do that.
Well, people will they'll always want human therapists to, from the initial that we did our first data analysis of like the first 38 minutes on the app, what happened to people's moods. And I believe we are going to be able to show that, that we can outperform a human therapist. And that could have tremendous implications for people all over the world.
Right, really could.
Yeah.
Yep. Okay, well, here's Simon's question. I have a question for you, Dr. Burns. I am very depressed at the moment, and I don't know what is wrong, or I have difficulty finding out what thought is giving me the down feeling. Is there a podcast that you can recommend for general depression and how to find out what's wrong? Thanks for this. Thanks so much. Thanks for I can't understand this. For the so great inspiration.
Yeah, okay. Right. Well, thanks, Simon. And Simon actually went to the 2 podcasts on 50 techniques in 50 minutes, podcasts 93 and 94, and put the time frame for each of the 50 techniques.
Oh, wow, cool.
So if you want to look up externalization of voices, you can see just what minute it starts and what minute it ends.
What an awesome thing for him to have done.
Yeah. But I think Simon needs to get into the basics, and I gave him some links to techniques, podcasts on how to use the daily mood log. I would suggest that you read one of my books, either Feeling Good or the Feeling Good Handbook or the new book, Feeling Great, and we'll really show you in a step-by-step way how to use the team model. It's not just, general. There's no such thing as general depression. We all have different thoughts and different feelings when we're depressed. And there are many ways to crush the distorted thoughts that cause depression. But again, as we've mentioned earlier on this podcast, you need to focus in on one specific moment, on one specific day when you were feeling depressed, and then fill out a daily mood log. Where were you at that time? What were your feelings? Circle them on the daily mood log and rate them between 0 and 100. Write down your negative thoughts, identify the distortions in them, and then do some positive reframing, and then talk back to those thoughts. That's the general overview. The devil's in the details, and you'll learn exactly how to do it in really any of my books.
Also, he could just start, or anyone could just start with podcast 1 and work their way up, because in the very beginning of the Feeling Good podcast, you went through all of this information.
Yeah, or if you like, there's a free depression test on my website and a free class. It actually sends you every 2 days all the relevant podcasts on depression that you can listen to. So we've organized it for you. So that's another great free resource on my book, feelinggood.com.
Yeah, that's cool.
And then the final one, which apparently you didn't get, but I think you'll enjoy answering it. This is from Stephanie.
Okay.
And she wrote, "Hi, David. I hope this is the right address to which to send an Ask David. I am a huge fan of your work and cannot thank you enough for making your therapy techniques so accessible. And thank you for taking audience questions, ! I am in the process of learning team and notice myself getting more skilled, slowly but surely. There are times I hear you help patients recover in a single session, which has to be 2 hours, by the way. So far, I've not found myself able to help patients that quickly. I've felt disappointed about this, and it's led to anxiety and self-doubt. I think I need to learn team faster so I can help my patients as quickly as possible. And I tell myself this should be happening quicker. I'm wondering how logical it is for me to expect myself to help patients recover in a single session. And by the way, I can't do it in a single session unless it's a 2-hour session, just as an aside. Is it reasonable to assume that I might have to practice team go through several experiences before I can help patients change that quickly? Thank you again, Stephanie. Well, I have a lot to say on this, and I'm sure you do too, and I'll give you the first shot at it, Rhonda.
Well, do you think that when you work with somebody for 2 hours and they've gotten over the anxiety or the depression, that's because it's only a one part of their depression or anxiety. Like with Karen, in your book, you talked about her in Feeling Great. You talked about her and her situation with her daughter. You weren't the first person or the first time, it wasn't the first time she ever talked about that situation when she worked with you. And, I think a lot of people have said something like that to me, like, oh, there's so much pressure to do it, to heal somebody immediately or completely, fully within 2 hours. And it's impossible to do that. On the other hand, when we were doing the COVID clinic, when we were providing, free sessions to people who are first responders working in hospitals and treating COVID patients, I worked with an ER doc who called me and said, I'm really anxious. I can't do my shift. I'm driving to to the hospital right now, and I need to get over this in an hour. And I thought, oh my God. And I actually went through the entire team model in an hour, but I limited it. I said, okay, tell me the moment in time when you had this doubt, and I'm only going to have the time to do 2 feelings. So just pick 2 feelings and then pick 2 negative thoughts for each feeling. And so I limited the amount of information that he gave me, but we did go through the whole team model, and we did 2 or 3. We did the positive reframe, we did the magic button and the magic dial, and we did the double standard technique, and we did externalization of voices. And after an hour, he felt better. And actually, I even did a brief mood survey a little bit before and after we worked together. But that kind of work, that doesn't happen very often.
Right. Well, when I'm working with people, I would say 90% of the time I see a complete elimination of symptoms in a single session.
Mm-hmm.
I've been at it a long time. There's this person who did research on expertise at Popular Research. I don't know it in detail, but so you have to do something 10,000 times to become an expert.
Malcolm Gladwell.
Yeah, perhaps that's probably who it was. And I've had more than 40,000 therapy sessions since 1977 or whenever I went into clinical practice. Yeah. And I've been measuring things that whole time and trying to improve. And it's only in my later years, when we've developed team, that I've been able to get such phenomenally rapid results. Or in my early days, if I got someone recovered in 10 or 12 sessions, I thought that was kind of a miracle, an amazing thing. But over the years, it's gotten faster and faster. And so you have to work at it. But when I used to tell myself when I had a long-term patient and that was resistant and not getting better, and of course, I didn't have all the good techniques there, but I always told myself the patient will get better at the exact correct moment. Mm-hmm. And they won't get better 1 second sooner or 1 second later. Everyone recovers at the exact correct time, so that I never pressured myself or worried about it. Mm-hmm. The main thing is I never gave up on a patient. And I never gave in to the patient's hypnotic suggestion that they were the one hopeless case. Mm-hmm. But there are things that you can do, Stephanie, to speed your learning. But the first thing is to be kind and patient to yourself, and give yourself a break. I would say that most of the therapists we're training in the Tuesday group, I think, don't get the kind of rapid results that I've been getting. I think some do. Sonny Choi, who's joining your institute,
yes, he is.
He does, and he does. Matt May does.
He does.
And there are some who get these phenomenally rapid changes. But you could be taking team therapy training. Join Rhonda's Wednesday group. It's free, for therapists from all over the world. There are beautiful paid trainings at the Feeling Good Institute, feelinggoodinstitute.com. I support them. I'm not affiliated with them. That confuses a lot of people. But they've got, Jill Levitt is a brilliant trainer. She does introductory training classes, 12-week training classes. My Christian son is a brilliant and warm, compassionate teacher. He offers 12-week introductory training classes. There's all kinds of training that you can do to add to it.
And I think Kevin Cornelius is about to teach a low-fee 12-week class, and he's fantastic.
Yeah. Kevin is fantastic, and he was in our training group, our Tuesday training group. But there's a lot you can do, but it would be nice if you could talk back to your negative thoughts and view it as an exciting journey and really fun to track your skills and your speed of recovery. You also want to be looking at your feedback measure at the start and end of every session, and then again, are you doing 2-hour sessions with your patients? Because if you're trying to fit it into the conventional 1 hour a week, it's going to take way longer to get people better, because you have to kind of start over each week. But I'm glad you raised this question, because I think there's a lot of therapists out there who are thinking, I should be able to get people better in one session the way David does, and then they're ticked off at David or ticked off at themselves. And I think that's sad. I like to show rapid recovery because I want people to see this is possible, because the field, I was trained to believe, and most therapists to this day still believe, that recovery takes months, years, or even a decade or more of treatment. But the last thing I want to do is to put pressure on therapists, thinking, you're going to have to be like David, or you're no good, and that's not a fair comparison. I've just always taken joy in learning and improving and looking at my data. And if I am not getting a good result with a patient, to get a consultation and find out what errors am I making. It's probably an error in agenda setting, and how can I improve my skills. The most important area of improvement needed by most therapists is to learn the assessment of resistance better, because that's where all the action is.
Yeah, and I could probably tell Stephanie that took me 3 years to learn. And I was doing a lot of, weekly training with Phyllis Cedars, and I was going on hikes, and every workshop you taught, I took, and I was doing tons of practice at home. And it's kind of a complicated thing to learn.
Yeah, and it's also kind of an aha moment when you finally kind of get it. There's still a lot of details, but there's something to get about not try to help, try to show patients why they shouldn't be helped, why they shouldn't change in a kindly way, using positive reframing. And that's just incredibly liberating. But I sure understand that pressure you're putting on yourself, because I used to put myself under a lot of pressure. And I still occasionally do, but most of the time I don't do that to myself anymore.
Well, I want to ask you a question without feeling oppositional, but don't you kind of, let's say, like, I'm working with somebody, hypothetically, who is dealing with the issue and is not doing homework and is not getting better. And no matter what interventions I make with this person to talk about process and outcome resistance, they're not doing homework, they're not getting better. And then I issue them a gentle ultimatum, which is, and sit with open hands and say, maybe this isn't the type of therapy for you. And they say, I don't want to do homework. Maybe this isn't the type of therapy for me. If I'm getting rid of, or if I'm terminating with people who aren't motivated to do the work, like in our previous podcast that we worked with, Bridget, she was really motivated. She did a ton of work. And she got better. Yeah. But if I'm terminating people because they're not doing the homework, how does that fit in with?
Well, see, I've never done that.
You've never done that? How do you do that?
No, I negotiated at the initial evaluation. Jill Levitt negotiates at the telephone conversation. She doesn't even get involved with people if they're looking for talk-only therapy.
Yeah, but people say sometimes at the initial conversation, sure, I'll do homework. But
do they fill out the concept of self-help memo?
Yeah, I always send that to people. And then sometimes
they fill it out and go over it with you?
Yeah, but sometimes in the process, absolutely, in the process of actually saying, okay, well, here's your homework, blah, blah, blah. And they go, I'll do it, but then they don't.
And that would be the second session they come back without having done their homework.
Uh-huh.
Yeah, well, then I would say, I'm sorry, I think I talked you into something that's not right for you. And there's a lot of therapists in the community who also don't believe in the value of psychotherapy homework. And you're free to go to any of them. And if you ever change your mind and want to come on back, I just would love to see you. But I wouldn't be stringing people along.
Mm-hmm.
And in my experience, when I make people accountable, they're much less likely to drop out. I got more dropouts in the old days when I was trying to persuade people and trying to help people.
Yes.
I used to help people do their homework,
mm-hmm.
and it never once worked.
I can totally see that, actually.
Yeah.
Because they have to generate their own internal motivation. They can't take it from you, from the therapist.
Yeah. Yeah. And a lot of people they don't want to do homework. They just want to go and talk. And if that's what you want, I say, God bless you. I believe in free will and accountability, and my door's always open to you if you ever change your mind.
Mm-hmm.
I think a lot of therapists don't want to make patients accountable and just think somehow they're supposed to help patients through talk and support and compassion and, insight-oriented therapy or whatever.
Mm-hmm. Well, it's not like we're not doing insight. People develop insight as they're doing the work in the home with us and at home.
Oh, yeah, absolutely. Mm-hmm. Do downward arrow technique, interpersonal downward arrow.
Yeah.
But anyway, that's my suggestions to Stephanie. I say, God bless you for asking this important question. I think it'll help a lot of therapists out there who are also wondering, what's wrong with me?
Mm-hmm.
Well, if you want to improve your skills, get more training, but maybe not so necessary to beat up on yourself.
Right.
To be patient with yourself and loving toward yourself and let your skills grow. I've just loved doing therapy my whole life, and getting better and better at it. It took me 40 years to get to where I'm at right now.
Wow, that's neat. Okay, well, this was a great podcast, and I think our next podcast might feature some more team therapists doing awesome work. And I also wanted to say that, the incredibly warm feelings that I have toward you, David, I think all team therapists have them toward you, and feel so grateful that you've created this and so willingly share it. And
Thank you.
Generous.
I'm just grateful to be a part of this community and just have so many awesome people to connect with and who think my work has value. When I was a teenager, I also had many creative ideas, but nobody ever took me seriously because I was a kid.
Uh-huh.
And now one of the benefits of being like an old fart is that, you have gray hair and a beard, and people think, well, he's so old, he must know something. And so you kind of get some respect, which maybe isn't always deserved, but it's just fun having a group of people working together as a team, developing this model. And for me, the model evolves every single day, practically every single week. And my latest insight, which I'll just throw out here at the end of the broadcast, is kind of a unified field theory of psychiatry and psychology, and that it's impossible for depression to improve, or any negative feeling to improve, without a reduction in the belief in the negative thoughts. Mm-hmm. That there's only one thing that can cause feelings to change, and that's a reduction in your belief in negative thoughts.
Mm-hmm.
Sue?
Very interesting, and I'm sure we'll hear more about that in 2021.
Okay, great.
Okay, thank you everyone for listening. Until next time.
Yep, bye-bye.
Bye. This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.